You sit down, and within 10 minutes, it starts. Deep, central, low back, not down the leg, not around the side, dead center, behind the belt line, a pressure that builds the longer you stay loaded. Bending forward to pick something off the floor is the worst thing you do all day. Lying flat gives you relief within minutes, which is exactly why nobody at work believes you. You have carried this for a year, maybe 3, and your imaging says almost nothing. Degenerative changes at 2 levels, no stenosis, no nerve root compression, nothing that explains why you cannot sit through a meal. I am an interventional pain physician. Let me show you what is actually happening. At the Padda Institute Center for Interventional Pain Management, this is one of the most common presentations I see, and the one the system handles worst. You are pushed through one of 2 doors. Behind the first, you are told the scan is unremarkable, your pain is deconditioning or stress, and you are handed a muscle relaxant. Behind the second, someone reads that same scan and offers you a 2-level fusion. Same images, opposite conclusions. Neither is a diagnosis. Here is the error, stated plainly. A lumbar disc that looks degenerated on MRI is not evidence that the disc hurts. Dark discs, height loss, and annular fissures are found constantly in people who have never had a day of back pain. Appearance is a population finding. Pain is an individual one. When a surgeon selects your fusion level from the ugliest disc on the film, that is an educated guess wearing the costume of a diagnosis. Provocative discography asks a different kind of question. It does not look at the disc. It interrogates the disc directly, and it is allowed to come back negative. I have seen discography ordered as a formality, a box checked on the way to an operation already decided. A test that is not permitted to say no is not a test. If I am not willing to tell you that your discs are not the source and that surgery is off the table, I have no business putting a needle into them. Understand what a disc is. A pressurized gel core, the nucleus pulposus, restrained by concentric rings of obliquely oriented collagen, the annulus fibrosus, anchored above and below to the vertebral end plates. In a healthy back, only the outer third of that annulus carries nerve fibers. The inner annulus and the nucleus are, by design, silent tissue. That design fails. In 1997, Fremont and colleagues published tissue work in The Lancet examining discs from patients with chronic back pain. In control samples, nerves stayed where they belonged, outer or middle third only. In the chronic pain specimens, nerve fibers had extended into the inner third of the annulus in 46% and into the nucleus pulposus itself in 22%. Those fibers expressed substance P, a neuropeptide of nociception. Read that again. Tissue that is supposed to have no sensory supply grows one. That is how a disc becomes a pain generator without touching a nerve root, without a herniation, and without one convincing finding on your MRI. The clinical entity is internal disc disruption, a radial fissure propagating from the degenerated core outward through the lamellae into innervated territory so that ordinary loading is transduced as pain, which is precisely why discography is never a first move. Deep axial low back pain has a real differential, and I work through it in order. Facet-mediated pain, tested with dual comparative medial branch blocks, not with a picture. Sacroiliac joint pain, with its own provocation maneuvers and diagnostic block. Radicular pain, which follows a dermatome and declares itself on examination. Hip pathology masquerading as back pain. Myofascial and gluteal sources. Only when those are genuinely excluded and your pain has persisted beyond 6 months, despite honest conservative care, does the disc come into question. And one more filter applied without apology. Untreated psychological distress and somatization change what this test means. In the systematic review by Wolfer and colleagues in Pain Physician in 2008, patients with somatization disorder showed a false positive rate near 50%. Prior discectomy, 15%. A painful iliac crest donor site, 12.5% Ds all per patient. Screening is not a judgment about you. It is arithmetic. Here is how it is done. You are positioned prone and obliqued under fluoroscopy. Skin is prepared with strict sterile technique and antibiotic prophylaxis is given. because the most serious recognized complication is discitis, infection of the disc space. New back pain with fever in the days afterward is an emergency. You call us immediately. Using a 2-needle technique, an introducer is placed extrapedicular, lateral to the superior articular process and anterior to the exiting nerve root, and a fine inner needle advances into the center of the nucleus. Then contrast is injected slowly through a manometer while I watch pressure, not volume. Pressure, because the entire interpretation depends on it. A positive level requires 2 things at once. The injection reproduces your usual familiar pain, concordant pain, not mere pressure, and it does so at low pressure, near opening pressure, not by brute forcing a normal disc until anything would hurt. And the element that makes the test legitimate, the control disc. I must pressurize at least one adjacent disc that does not reproduce your pain. Without a negative control, a positive result is uninterpretable. Afterward, CT grades how far the fissure has propagated through the lamellae, and that grading, with the pressure data, goes into your report. Now, the honest evidence, including the parts that do not flatter the procedure. Wolfer's meta-analysis pooled 11 studies and found a specificity of 0.94, confidence interval 0.88 to 0.98 when strict standards are applied. Overall false positives ran about 9% per patient and 6% per disc. There is no independent gold standard for discogenic pain, so sensitivity is unknown, and the evidence sits at level 2-2. This is a good test, not a perfect one, and anyone who tells you otherwise is selling something. The second risk is the disc itself. In 2009, Karagi and colleagues published a 10-year matched cohort study in Spine, the ISSLS prize winner. Degenerative progression occurred in 35% of punctured discs versus 14% of controls, with significantly more new herniations, falling disproportionately on the side of the annular puncture. That study used small gauge needles and limited pressurization. Gentle technique did not prevent it. In 2019, McCormick and colleagues published a 7-year matched cohort, also in Spine, using low-pressure Spine Intervention Society standards, and found no acceleration. I take that seriously. I also read it accurately, retrospective, in symptomatic patients who did not go on to fusion. It lowers the concern. It does not settle it, so I hold a hard line. Discography is reserved for patients actively contemplating surgery, where knowing the responsible level would change what is done. Whether that improves surgical outcomes remains debated. A positive discogram is one input. It is not a green light. What I'm about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. 3 years of central low back pain, worse sitting, better lying flat, physical therapy, medication, time, facet sources evaluated with comparative medial branch blocks, negative, sacroiliac joint excluded, an MRI showing changes at 3 levels and answering nothing. A 2-level fusion had already been proposed. Screening came first, including a candid conversation about mood, sleep, and distress. At discography, 1 level reproduced the exact familiar pain at low pressure. The level above it, fully pressurized, produced nothing. A second control disc, also silent. CT showed a fissure reaching the outer annulus at that single level only. What was hard? The waiting and several days of increased soreness afterward, and the honest possibility, discussed beforehand, that every level would come back negative and surgery would not be indicated at all. That happens. It is a legitimate result, not a failure. What changed? A 2-level operation became a 1-level conversation, informed rather than inferred. Recovery took months, not days. Nutritional and metabolic support ran alongside as an adjunct in discogenic pain. That evidence is emerging, not established, and it substitutes for nothing. If you have deep axial low back pain past 6 months, a scan that explains nothing, and someone is discussing fusion, you are entitled to know which structure is generating the pain first. Learn more at painmd.tv under Pain Treatments, Discogram. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Ask the disc, then decide. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.